Hello and welcome to another edition of The Voice of Aging. I'm your host, Bryn Malone with Aging Solutions. Again, we're welcoming Kathleen Giannette, who came and visited with us about hospice before. And today we're going to talk about palliative care.
Yep.
And if you haven't seen the hospice video on YouTube or listened to it on Spotify, I would encourage you to do that because today we're going to kind of create the circle or finish the circle and let people know how those things can go together and how one might really lend itself to helping the other,
Yeah.
right?
Perfect.
So, okay.
Yes.
Yeah. So I appreciate you coming back and enjoying another podcast with us and excuse me, and helping the people understand really what's available to them.
To do it. Thanks for
Resource.
having me.
You're very welcome.
Yeah.
So reminder, folks, again, who you are and what it is that you do.
So my name is Kathleen Giannette, and I am a hospice liaison.
Okay.
And what I do is I provide information to doctors' offices, hospitals, families about what their options are when it comes to the choices that families have when there's a life-limiting illness.
Okay, so you're the first point of contact a family's going to see?
Yes.
Okay. And then your job's to welcome them and also let them know what the expectations are?
Yes. Sit at their feet, ask questions, answer any questions.
Okay.
There's not any hurry when these visits take place. I
Okay.
want to make sure that when I leave that they realize that they feel better suited, better prepared
Okay.
when I leave.
Remind us again, what are some of the common questions you get, whether it's for hospice or palliative care, just when somebody's struggling with a chronic illness or a terminal illness?
So I think probably one of the biggest questions is, does this mean that my loved one can never have any treatment? Like
Okay.
if they get a UTI or if they have any sort of an infection, you guys don't treat that, right? And the answer is absolutely not. We do treat infections.
Okay.
We treat with antibiotics, or they'll say, well, then mom can't ever go to the hospital. Well, no, she can, but does she want to? And if we can come at 2 in the morning on a Saturday opposed to 911 taking her down the mountain in the middle of a snowstorm, which would you prefer?
Right.
And then they're kind of like, oh, that sounds better.
Yeah,
We like that idea better. Yeah.
The nurse will come to see us and we don't have to go through that. It could
And
be
I
a
think
lot.
a lot of other people think that hospice is a place. Well, why do we have to take mom to hospice? Well, hospice is not a place. It's a concept.
Yeah.
And so typically, I'd say probably 99% of our families are either in an assisted living or at their own home.
Okay.
But they don't get to pack their suitcase and go live in a hospice house when they're first diagnosed or when they're first eligible for hospice.
So again, give us a definition of what a hospice patient kind of looks like.
Yep. So a hospice patient looks like somebody who has a life-limiting illness and that they don't really want to continue to do the traditional treatment. They don't want to go to chemotherapy. They don't want to go to dialysis anymore. They really don't want to have home health physical therapists come in 3 times a week making them do heel pumps. They don't want to do that anymore.
Heel toe.
Exactly, exactly. So what they really want is a level of comfort. And also, so many people, especially women, are concerned about how their family is going to do. And so they want to make sure that we can come in and provide that psychosocial support for their loved ones too.
Okay, that's
not
great.
just the patient. Yeah.
But let's say, excuse me, that I'm not to that point in my life, but I'm struggling with something. I'm just not as well as I once was.
Sure.
There's the partner to hospice is what I would call it. And maybe you have a better term for that. If so, want to hear it. And that's called palliative care.
Yep.
Can you tell us what the palliative care is and how it's used and why it's different than hospice?
Yes. I was sharing with the ladies that sometimes it's not a fair concept, but sometimes people use it synonymously with hospice. They think, oh, hospice is a scary word, so let's say we're going to go on palliative care.
Yeah.
Well, it's misleading because honestly, Bryn, palliative care is for those folks who might need help with their symptom management. Let's say they're doing chemotherapy and they're doing radiation, but along with that, they've got the nausea, the vomiting, the constipation, the overall body aches. A palliative care practitioner can be part of their care team and can prescribe medication to help them through with those symptoms. They can still do the treatment, they can still go to dialysis, still do chemo, they can still get home health, but they're not a full-on hospice patient yet, but they need some help in the interim.
Okay, so let's say that somebody has a terminal disease and they're in the, I'm going to say, the battling stage,
Yeah,
right?
it's a great way to put it.
They're
Mhm.
really, they're going to fight it, and we hope that they beat it, right?
Yeah.
But in that interim, they're not on hospice because they're not. I use the term terminal illness, or
Mhm.
what was the term that you use for people who are short-lived?
Imminent.
Imminent, yeah,
Mhm. Mhm.
imminent.
Mhm.
Palliative people are not necessarily imminent. They're in the, I think it's called the curative stage.
Correct.
Okay, they're still
Mhm.
trying to seek cures for
Mhm.
whatever their disease process might be.
Right.
I'm sure cancer is probably a big one.
It
Are
is.
there some others that
There
people?
are a lot of kidney disease.
Okay,
Sometimes dialysis can be really rough on a person. They get
Mhm.
very nauseated. And so instead of the next day going to the ER, getting medication for nausea, their palliative care practitioner can ahead of time order some medication so that the next day after dialysis, they can have that medication on board.
okay.
Mhm.
So it sounds like nausea is kind of a big thing when we're having these kind of very
Yeah.
extreme treatments, chemotherapy, dialysis.
Yep.
What other kind of disease processes are palliative care appropriate?
I would say anything that's neurological.
Mm-hmm.
Like, let's say that somebody has ALS, but
Okay.
they still, or Lou Gehrig's disease, but they are still trying to exercise their limbs, and they still need a nurse to come in to make sure that their wounds are addressed.
Okay.
That would be home health would be part of their team, and then a palliative care practitioner would be the other part of that team. And sometimes a palliative care practitioner, there might not be anything that they can really do except for bridge the gap. Because when that person and that family is ready for hospice, instead of going back to the hospital, the palliative care practitioner can reach out to a hospice agency that they're connected with and say,
Mhm.
Mr. Smith has now decided that that was his last chemo treatment. He doesn't want to do that
He's not going to
anymore.
do that anymore. He's
Mm-hmm.
done fighting that battle.
Yes.
So we have neurological disorders
Yep.
like Parkinson's,
Parkinson's disease is a big
ALS.
one. Mm-hmm.
Okay. And then kidney disorders.
Yes.
You might be on dialysis. You may not be on dialysis, but you
Right.
might have kidney disease, right? Chronic
Right.
kidney disease.
Mhm.
Okay.
And if you are a dialysis candidate, then you can pursue dialysis if you're
Okay.
on palliative care.
So what I'm hearing, the big difference is palliative care is there to walk along with you when you're you are really fighting your disease process and you're
Yeah.
trying to extend your life.
Yeah, it's extra support.
Extra
You
support.
know, all hands on deck. Why
And
not?
and how's that work? Do I have to go to a palliative care office?
No, palliative care office comes to you.
Okay.
So you reach out, again, go to the Google, type in palliative care in your area.
Okay.
Hospice agencies are more widespread. They're more well known, but a lot of hospice agencies also have a palliative care sort of arm
Arm.
to them.
Yeah.
Mhm. And so that's how you would find that. And then you would need to get an order from the doctor. The office can, like the hospice agency can help get the order from the doctor, but most doctors want to hear from the patient or their representative first. So I always tell my families, I'll call Dr. Smith tomorrow,
Uh-huh.
but you call him today.
Okay.
You get the ball
Ball rolling.
rolling for the hospice order or the palliative care order, and then I'll follow up tomorrow.
So does that replace my doctor?
It can.
I've been seeing Dr. Tom for 30 years.
Dr. Tom is going to wish you well, but Dr. Tom does not want to be woken at 4 in the morning on a Saturday
Okay.
because someone's in pain. So you don't have to give up your primary care physician, but most of the time those primary care physicians want you to be with a specialist,
Okay.
and that's where palliative care comes in.
So how often can I expect to see palliative care? Like with hospice, it's every couple times a week or once a week. It depends on how you're progressing
Mhm.
with your disease process. What's it like for palliative care? I mean, this could go on for many months, for years,
It
right?
sure
So
could. Yes.
how's that
Yes.
work?
So typically the nurse practitioner will schedule a visit. Like sometimes it's twice a month.
Okay.
As long as that person's doing okay, it's twice a month. They might call on the other 2 weeks.
Mm-hmm.
But with palliative care, that's what you get as the nurse practitioner. There's not a social worker involved, there's not a chaplain,
Okay.
and there's not a bath aide. That Medicare doesn't pay for that.
Okay.
If you want those services like a bath aide, you would need to find provider services in your area to maybe come over 3 times a week to give mom a bath or whatever.
Private duty care,
Correct.
or if you're qualifying for home health. That's
Yes.
another, as long as you have a physical therapist. So
Yep.
can palliative care work with home health if I let's say I just get home and from the hospital and I'm weak, and they send me home with physical therapy orders, and I got some new medications on board, and so they put a nurse in there also. How does that work? Is that going to be confusing? Does the palliative care nurse practitioner dictate what medications I'm going to be on, even though they came from the hospital doctor? And how's that reconciliation?
Yeah,
You know,
so
it's
it's
confusing.
a conversation confusing, and we don't want it to be, but it's a conversation that the practitioner should have with the families.
Okay.
Okay, grandma's on 67 pills and she's
Yeah.
having a hard time swallowing. Let's put the ones over here that she has to have. Anything for her heart, blood pressure, diabetes, the fish oil and the vitamin D and the, the gummies. Let's put those off to the side. But back to your original question, palliative care and home health can coexist.
Okay.
And those two entities should be in connection with each other to visit about their patient, their common patient.
How that's looking, how it's going on.
Yeah.
And so when the palliative care person comes out, the nurse practitioner, what are they going to do? I mean, is it like a doctor's visit if I go to the actual doctor's office and see Dr. Tom?
It's a little bit different from going to see Dr. Tom.
Okay.
That relationship has to be established. And then the practitioner is going to ask the patient and the family, what are your goals of care? Like, what is your goal? Do you guys want to see this lung cancer through? Do you guys want to continue chemo? Do you want to go to radiation? Are you interested in a trial medication? Or are you guys just sort of buying time until maybe the rest of the family's on board with hospice? Are we trying to do a process of elimination where, okay, we're going to give grandma one more try. She's 99 years old and she suffers from what we call TMB, too many birthdays.
Okay.
So
too many birthdays.
if she has
Okay.
TMB,
Is there ever such a thing, though? I'm just going to say.
no,
No,
there's
no,
not.
no.
I think our oldest patient has been 107.
Okay.
Yeah, and that was when I was working in the South.
That's great.
Yeah, I think she ate bacon grease for breakfast or something. I don't know. Yeah.
Good Southern cooking.
That's right.
So palliative care can exist with home health agencies, private duty agencies in the home. It's really there to have more frequent eyes on the patient,
Right.
to help manage nausea, medications,
Any sort of symptoms.
symptoms or side effects that
Yes.
you're having.
Yes.
And it's during the curative process. And I think it's for people who have chronic diseases, right?
It is.
Okay. What's a chronic disease?
Well, kidney disease is chronic disease.
Okay.
Anything with their lungs, neurological disease can be chronic.
Okay.
It can be a sudden onset too. It can be an acute situation where somebody's had a stroke, but they want to go home after they've been to the hospital, then they go to skilled nursing, then they go home on physical therapy, but they still need that palliative care to kind of oversee any sort of symptoms.
So a palliative care patient can be on palliative care for years,
Correct.
right?
Yep.
Okay.
Absolutely.
And so as a family, I want that for my loved one, because I know that I'm not on this journey alone. I've got somebody coming to the house.
Yes,
And do they go to private homes?
they do. Absolutely.
Okay.
Double wide, single wides.
Well,
It doesn't matter. A boat, wherever they call home.
okay. Because a lot of it's different from a visiting doctor situation then, right?
Yes.
Because a lot of the visiting doctors will, and there's different types of that. So we'll get into that on different podcasts with the appropriate people. But some of them will not go to individual homes.
Right. They only go to like assisted livings,
Right,
or
to
skilled nursing
communities.
facilities.
Yeah, okay.
Yeah, we need the black bag doctor to go to the patient's homes again. We need to do the Little House on the Prairie all over again in 2026.
Not really cost effective, I think,
I
if
know
you're
it's
trying to have a thriving or just a stay afloat business.
Yeah.
Which brings me back to this. How do palliative care companies stay afloat? How do you get paid?
Well, it's Medicare again, or if they're younger than 65, then it's their traditional insurance. Palliative care is not as lucrative as hospice is, and so that's why there's very few agencies out there that have the palliative care, because it doesn't pay like hospice does. Yeah, it doesn't pay like hospice gets paid.
My understanding is, correct me if I'm wrong, is it pays like a doctor visit would pay under Medicare Part, I think it's Part B.
B.
Is that right?
Correct.
Okay. And so there could be a copay for the patients under that?
We try not to, but
Okay.
sometimes there might be. Depends on
Okay.
their policy,
Yeah.
really.
So,
Mhm.
and then if I'm a family member, what kind of questions should I be asking? Or if I'm the client and I'm fighting the chronic disease and I'm like, Kathleen, I'm going to be here forever. So you guys are going to be with me.
Yeah.
I just can't get out and about like I used to. What kind of questions should I be asking?
I would definitely ask the type of visit, how often they can come,
Mm-hmm.
if they're available on, on the weekend, if that scheduled appointment is solid, or can I call you the day before and say I need you to come over today? Who refills the medications? I would ask questions
Mm-hmm.
like that.
Okay. And then what's communication like between, because let's say I don't have a printer or Wi-Fi, but I want to see my visit note, or my family wants to see my visit note.
You just have to request it from medical records and they should be
Okay.
able to get it to you.
So
Yeah.
palliative care is electronic. I'm sure they carry tablets or computers,
Yes.
right?
EMR,
EMR,
electronic medical
records.
records.
Yeah.
Yes, another fun acronym in the world of medicine.
Yeah.
Yeah.
Okay, so I'm doing that and we're clicking along here and I'm doing pretty well. Like, but I just, let's just say I have palliative care. Is it ever just because I'm old?
TMB, too many
Too many
birthdays?
birthdays?
No,
No.
you have to have a life-limiting illness, and you have to have a symptom that we can help control, that any
So
palliative
what's
care
a
can.
life-limiting illness if I'm just old? That's kind of life-limiting. You know what I'm saying?
It should be, right?
Yeah.
It should be.
TMBs are getting fewer and fewer.
I know.
Yeah.
So a good practitioner is going to go through your medical records with a fine-tooth comb, and they're going to see if
Okay.
there's anytime anybody has even suggested that you had, heart issues or lung issues, or that you've had an MRI and the brain has shrunk a little bit so that there's maybe some dementia. They're going to look for those.
What about wound care?
Wound care would be through home health, through the nurse. Mm-hmm.
Okay. So palliative care is really for really powerful chronic diseases. And we've listed some of those chronic diseases, but what's the difference? You mentioned the term acute.
Mm-hmm. Yes.
So what's the difference between acute and chronic?
So chronic is something that you've had for a long time and you've kind of dealt with it. Acute is something like a stroke that happens just like that.
Yeah.
A stroke or a cancer diagnosis, it's an acute onset of whatever that disease is.
Okay. And what about heart failure? People who are just really, COPD
Yeah.
or CHF and they're can't manage their water intake and
Yes.
output
Yes.
appropriately.
We would talk to the families about signs and symptoms to look for with that fluid overload. We would
Okay.
talk to them about their diet. We would ask their family to keep a log of their weight, because if there's a weight gain, sometimes it's fluid.
Okay.
And instead of going to the hospital and pulling off 30 pounds of fluid, like I had a lady the other day, she lost 30 pounds in like a matter of days.
Okay.
I want to know her secret. But anyway,
Well, that's not fun to do
no,
that.
it's not. I'm
No.
just kidding. I'm just
No.
kidding. But our practitioners, or a palliative care practitioner, would talk to the families about, this is what it looks like to be a stable congestive heart failure patient.
Uh-huh.
But when you start to see the puffiness, or you start to hear them being wheezy,
Rattly, yeah.
and rattly, then call me, because we might need to fluctuate the diuretics, or we might need to, do something a little bit different.
So is that appropriate for palliative care? If a CHF person who's probably not functioning very well, would they be appropriate for palliative care?
They would be appropriate for palliative care, and sometimes it's up to the practitioner and the families to kind of say, okay, let's just watch and see what's going to happen. This
Yeah.
man could be stable for a long time,
Yeah.
but palliative care could get started, and then 3 weeks later, he's huffing and puffing, he needs more oxygen, he's been to the hospital a few times. It's time to really look at, okay, let's talk about quality of life.
Uh-huh.
Do you want to keep doing this? Do you want to keep going back and forth to the hospital, or do you want to just, sit on your back porch and watch the sunset and let us come in and provide comfort measures
So
for
the
you?
nurse practitioner would talk to the patient and the patient family about that.
Correct.
And then the next step is
Hospice.
hospice.
Yes.
Okay.
And it's a beautiful transition, because anytime that you have a physician or a doctor or a nurse or physical therapist that you know and trust,
Yeah.
you'd probably jump off a bridge for them, right?
Right.
Because that's what we do.
Yeah.
So the practitioners want to make sure that they're just being upfront and level as possible with these families, we don't want to come in. No practitioner wants to come in and kind of say, okay, this is what we're going to do. No, it's your life. This is your family. We're guests in your home.
Yeah.
So what does it look like? What does quality of life look like for you? Not for your wife, not for your son.
Mm-hmm.
What does it look like for you?
Okay.
And let's mold our services around that.
Okay. So I think we've answered a couple questions today,
Yeah.
right? And I think we've gotten right to the point. So one, palliative care is for people who are battling their disease.
Mm-hmm.
And they're typically chronic diseases or can be acute, meaning
Right.
that it was sudden like a stroke.
Mm-hmm.
And they're trying to live longer. Let's just say that,
Yeah.
right? They're trying to have more birthdays.
Right.
Okay. And then palliative care and hospice, oftentimes a hospice agency will have a palliative care arm.
Right.
And that's one way to have somebody who has a chronic disease transition easily to more imminent or end of life care and renew how their mind is working as far as their quality of life and what that really means to them, carting off to the hospital or not, and
Right.
those kind of issues that we've discussed. And it's paid for a little bit differently, where hospice is paid for by Medicare Part A.
Correct.
And this is just like a doctor's visit,
Yes.
but I can still have my doctor.
Yes, you can.
And my nurse practitioner from palliative care will work with my doctor, but this nurse practitioner is going to come and make sure I'm doing okay, adjust my medications as they see
Right.
things change.
Mm-hmm.
Where
Also offer let's say that they can tell that the spouse is getting weary. The palliative care practitioner can provide resources.
Okay.
Have you thought about having caregiving services
Come in the house.
Yeah, some families don't know that even exists.
Yeah.
Or if they're a veteran, but they've never tapped into their VA benefits, well, the practitioner could help figure that out and help the family get that going.
Okay.
Yeah.
So it's a really great resource. And
Yes.
the more help we can get, the better life we can have.
Amen.
Right?
Can't agree with you more.
Okay.
Yes.
Somebody agreed
absolutely.
with me. I love that.
That's right.
Yeah. We got one today.
You can pay me later.
Okay.
Kidding.
I will. Well, Kathleen, I always ask, is there anything that I missed? I should have asked you that I didn't.
Gosh, well, maybe, I don't know if you haven't asked me this, but sometimes people appreciate that word palliative versus hospice, because palliative sort of is like hospice light, is what some people say.
Hospice light.
Mhm.
Okay.
So yeah, the pre-hospice. So, and sometimes it can be used in that manner. It doesn't always have to be that way,
Yeah.
but sometimes, if that loved one still wants to continue going down the curative path, even though it might look like they're not really winning that
Yeah.
battle,
Mm-hmm.
we offer them every bit of support that we can.
Okay.
Yeah.
Yeah. And it's, just from personal experience, I always like to throw this in because I've been doing this for a long time, is I have people on palliative care
Mhm.
and some have gone on hospice and come back off hospice back onto palliative care.
That's right. It's
'Cause
very fluid.
It's very fluid.
Mm-hmm.
Some have been on palliative care for years and never gone on hospice because
Right.
they're stable.
Yep.
But we have introduced other resources
Yeah.
for them. So that's been wonderful. And but palliative care, it's a calling like anything in healthcare.
Mhm.
And it does not pay nearly as well for a company
Right.
as does the hospice piece. And I think it's just important to our viewers to understand that you want to ask a lot of questions as always,
Yes.
and not feel like you're being rushed into hospice, for example,
Yes.
and that palliative care is still appropriate, but measure that by communicating with the loved one who's still in the curative process or, trying to
Exactly.
get well, or trying to just maintain what we call the baseline.
That's right. That's
Yeah.
right.
And I would ask one more question. Like, we talked a lot about the nurse practitioner coming in and managing nausea and different medications and so forth. Is that all they do, is just kind of manage medications? And you've mentioned bringing in other resources, but what are those resources? What does that look like?
So let's say that they are working with a patient that has Lou Gehrig's disease.
Okay.
And because that patient is bedbound, they're starting to get wounds or skin breakdown.
Okay.
The nurse practitioner is probably going to reach out to the doctor to get an order for wound care. Either the nurse from the home health agency can come to the house to provide the wound care, or if they're more if they're able to get out, they might be able to go to a hyperbaric to help with that wound,
Okay.
because that's a level of comfort.
Okay.
Let's say that they get there to a patient's home and the patient has congestive heart failure and they don't have a hospital bed. So that patient is laying flat. Well, when you lay flat and your lungs start to fill,
Uh-huh.
you short of breath, you feel like you're drowning. So they can also help with the equipment. Anything that's, here's another acronym, DME, or durable medical equipment.
Okay.
They could help figure out, okay, grandpa needs a wheelchair. We need a bedside commode. We need a hospital bed. We have to get orders for that so that the home health company can get approval from the insurance company, and then get the equipment company to bring
Okay.
that out.
So that's another way that you work with the home health company. The nurse practitioner can write the order. The home health care company then will take that order and get all the equipment in place, usually through a physical therapist or occupational therapist.
Correct.
Right?
Yes.
And then bring it to the home, train the family and the patient on the equipment, and get it sized, based upon your height and all those
all the
things.
things. It's
All the things.
typically a medical equipment company.
That does
Up
that.
here, there's
Okay.
a couple of them that we work with,
Okay.
and it's their own company, and so they'll come out with a walker and make sure that it's measuring
Adjust it,
right,
right?
or if it's a wheelchair, if they need just a transfer chair, maybe to get them, in and out of the car, or
Okay.
take a walk, or whatever the case may be.
Okay, a slide bench, whatever it might be, to get in and out of bed. Okay.
That's right, and
All
out
right.
of the shower.
And the shower too.
Big trip hazard is that shower lip.
Okay.
And also when somebody is wet and soapy, it's fall
Yeah,
risk.
fall
So
risk.
we want to make sure that they're safe in their surroundings.
Well, I think that's another point with that is if you're seeing your primary maybe once a year for your annual, but you're maybe done with chemo for a while and you're not going to see your oncologist for a while, your other specialist, your neurologist,
Yeah.
maybe that's every 6 months or 9 months.
Right.
You might have something going on
Right.
that without having palliative care involved.
You'd have to kind of start over by going to
Yeah.
the ER.
Yeah.
hmm
So
Nothing
this,
wrong with going to the ER, but when you're
Right.
not feeling great,
yeah, it can be changed. So
yeah.
just having palliative care if that's appropriate for your
Yeah,
disease
for sure.
process and your specialists are on board, everybody's on board. I think that's great.
I
So
always say knowledge is power, and I like to give families as much information as they would like at that time. And sometimes they're not ready for those services, but at least they have that in their pocket.
yeah.
And then that way, we had a gentleman last week. He had a kidney replacement like 25 years ago, and he just stopped taking all of his anti-rejection medication. So we went over
Self-diagnosing.
and he was just like, I'm done. But then the next day he said, just kidding. And he started taking the medication again. Well, this morning he called back and said, okay, now I'm really done.
Okay.
So, we have to just kind of wait sometimes for that person. It's their life, it's their care. So we want to honor that.
Okay.
Yeah.
Okay. Well, that was a good one. Anything else that we need or should cover?
The only other thing that I would maybe suggest is palliative can be an extra layer, because sometimes the patient is kind of ready for comfort measures, but the family is not.
Yeah.
And so, that palliative care practitioner is going to do their very best to give that patient quality of life. But at some point, their frequency of visits is not as often as hospice. They don't have the CNA that can come, the chaplain that can come. And so sometimes the families are finally like, okay, we went down every single avenue except for this one over here. So before grandma gets imminent, let's go down this avenue and allow her to have a comfortable life.
Yeah, so we have a podcast about aging solutions and being an aging advisor, what that looks like. And we brought up different advisors that help support people as they age and support families as they age.
Yes.
And I think you make a good point there. Some are ready and some are not. And so having that advisor in there with eyes on and can speak to it
Yes.
from a professional standpoint, a medical standpoint in this case,
Yeah.
give expectations, let people know really what this looks like going on, because there's just patterns. Everyone's different. Like some people live longer than we think they're going to, and some pass away a lot quicker than we think they're going to.
Absolutely. There's only one that knows, and
There's
he's
only
not.
one. Not here.
He's not here.
He's not being interviewed right now. So I think that's just really a key point, is that the more support or advisors you can have,
Yeah.
that, especially if you get to know them by having them come into your house once or 3 or 5 times a month, whatever it might be,
Yep.
is great. So
Yeah.
again, Kathleen, I appreciate you being here. I want you can go ahead and give a plug to your company. We're in the Pacific Northwest and your company's in the Pacific Northwest.
Yes.
So how would
Yes.
they find you if they wanted to reach out and say, Kathleen, I need some help?
Can I give my phone number?
No,
Okay.
just give your
My agency? Okay.
your agency.
I work for Eden Hospice. We have hospice, home health, we have caregiving services, and we're soon to have our own palliative care.
Oh,
Yes, so that's
So
coming July of this year, so next month.
that's a secret or not a secret?
Not anymore, it's not.
It's gonna be out.
It's a grand opening.
Well, good for you guys.
Thank you. We're very, very
I
happy.
think that's great.
Yeah.
That's great. And you guys, I've used you for all your services, and it's just had really great experience. So
I'm happy to hear that.
very responsive, and I appreciate that.
Yeah, that's really important.
Yeah,
Yeah.
it is. So
It's funny,
important.
sometimes I'll get a referral and I'll call the patient, and the patient's family will say, we're just getting in the car from the doctor's office. And others, I called a gentleman last week and he said, well, I'm waiting for my oncologist recommendation. And that was literally 7 days ago. He still hasn't heard from anybody.
Oh,
That is not okay. And
That's
I
not
shared
okay.
that with him. I said, well, interview a couple of different agencies, and probably no more than 2.
yeah.
But if they're not responsive the first interaction, how responsive are they going to be? This isn't in my mind. I'm thinking,
Yeah.
how responsive are they going to be
You're
when you
thinking
really
out
need
loud.
them? Yeah.
Yeah.
At Thursday morning at 3 a.m. when
Yeah.
Grandpa's thrown up, like they're going to wait 10 days to call you back? That's not good.
Yeah, not good.
Yeah.
Yeah, there's choices.
There's always choices.
There's
Yes.
always choices.
And it is family choice. Even if your doctor says, I'm going to send you to ABC Company,
Mhm.
that's great. You can go with ABC Company, but you don't have to. You can
Yeah.
choose a different agency
You
if
can
you want
interview
to.
your own. Right?
Absolutely.
Okay. And if you're unhappy with your choice, you can
Yes.
change, whether it's palliative care, hospice, home health,
Correct.
right?
Yes.
Okay.
Yes.
Good.
Again, very fluid.
Very fluid.
Yes.
I haven't forgotten everything, but I'm working on it.
You're doing good.
Okay. Well, that's another edition of The Voice of Aging with your host, Bryn Malone of Aging Solutions. You can follow us on YouTube, Spotify, Facebook, Instagram. Go to our website at agingsolutionsnw.com. Please look at our services and our products, and we'd be happy to assist you. Again, this is Bryn Malone with Aging Solutions.